So can I start?
Yes, please.
48-year-old housewife was referred to the OP with pancytopenia for evaluation. She
Okay,
gives
wait a minute, wait a
history
minute.
of
What is meant by pancytopenia? What do you mean by the term pancytopenia?
pancytopenia means it means the person has anemia, leukopenia, and thrombocytopenia.
What should be the cutoff point for platelets, and what's the cutoff point for white cell count?
Platelets less than 100,000 and WBC less than 4,000. That is in mild pancytopenia. In chronic, it might increase. The values may change.
Okay, okay. Okay.
So can I continue?
Wait, wait, wait. Stano. Recording has stopped. Oh, okay. So pancytopenia means reduction of WBC, RBC, and platelet count. Okay.
Yes, sir.
Hmm.
So can I continue?
Please.
She gives history of tiredness, weakness, anorexia, dyspnea on effort,
Stop,
and
stop, stop.
she has history
How do you explain these four complaints? Dyspnea on effort, tiredness, weakness.
tiredness, weakness, and anorexia. Uh, as she is being referred for pancytopenia, either she might have some anemia, some type of anemia, or a chronic illness,
Okay, fine.
or
So reduced hemoglobin can produce effort, dyspnea, tiredness, weakness. Some
dyspnea,
chronic
tiredness,
illness
and
may be
weakness.
there. Okay, agreed.
So can I continue?
Please.
Then she was diagnosed with
She has got
carcinoma.
unmeasured weight loss.
She has unmeasured weight loss.
So okay.
Uh,
2014.
and she was 2014 she was diagnosed with carcinoma stomach,
Hmm.
and she had done gastrectomy for that.
Okay, gastrectomy was done followed by chemotherapy, and she was absolutely well.
Yeah.
So what are the
That's the
possibilities
history.
that comes to your mind now?
Sir, as she had done gastrectomy, that is also passed for like it has been like 6 years since gastrectomy. So, due to gastrectomy, she might be suffering from some type of vitamin deficiencies, like B12 deficiency. Then there is marked weight loss. This also might be due to the deficiencies of like there might be any small bowel obstruction, or appropriate nutrients might not be absorbed from the body.
Bowel obstruction, but there are
And
no symptoms and signs of bowel obstruction.
yeah, there are no symptoms.
Hmm.
Then
Is it possible?
she might.
Is it possible that the CA has infiltrated her bone marrow?
Yeah, it might be possible.
Okay. Or it can be some other disease unrelated to it.
It can be like AIDS. AIDS can have similar type of presentation.
AIDS. AIDS. Okay. AIDS. You are going to
Then
AIDS in this patient. Okay. So tell me some causes for pancytopenia. When the moment, because you put only one diagnosis, stomach is removed, deficiency. Now you said the secondaries. What other cause of pancytopenia? The moment somebody
there
says
can be
pancytopenia, the third case means partially investigated.
one of the cause can be aplastic anemia.
That's very good. Aplastic anemia. Which part of India aplastic anemia
Then
is commonly seen?
the northern India.
Which part of northern India?
That is it.
The banks of
Then
Ganges. Banks of Ganges. That's our endemic belt for aplastic anemia in India. There are many reasons for that, but that's a not northeast. Not northeast. Okay. Any other cause?
Then leukemia.
Leukemias can produce. Okay, fine. So you said one cause for aplastic anemia, which all the three elements are affected. Now we are going to WBC problem. Okay. Any other?
Then like we saw in the case, carcinoma can cause
You mean infiltration? Infiltration.
infiltration. Bone marrow
Okay.
infiltration.
Infiltration can produce. Okay. Yeah. Tell me some other cause. Any other, since you
Then
started with the bone marrow problem, aplastic anemia, what are the other bone marrow problems? Primary bone marrow problems.
other problems can be myelodysplastic syndrome.
Myelodysplastic syndrome. It can be
Can
myelofibrosis,
yeah,
or it can be
myelofibrosis.
osteopetrosis, the rarest of rare. Osteopetrosis. Well, okay. Tell me some problems.
Then lymphoma.
Lymphoma can infiltrate. That is coming into the metastasis. Lymphoma can infiltrate
Yes.
any other cell.
Then myeloma.
Myeloma. That's good. Myeloma. Before that, any other problem? Any irreversible factors you can think?
Reversible factors. Due to this aplastic anemia can be due to drugs also.
Yeah, that is causes of plastic anemia is different. More common.
Then hematopoietic causes megaloblastic anemia will be there.
What's the cause? Pancytopenia cause.
Yeah, sir. Megaloblastic anemia.
Due to what?
So vitamin B12 deficiency.
So megaloblastic anemia is the term, and you can demonstrate megaloblast, the cause of which can be variable. B12 deficiency, folate deficiency, MDS, all can produce. Okay. So megaloblastic anemia does not necessarily mean B12 alone. Can be other factors.
Okay.
Okay. What about autoimmune diseases presenting as pancytopenia?
Autoimmune diseases.
SLE, SLE.
SLE.
Any other hematological problem related to complements, where patient can have arterial thrombus, venous thrombus, prothrombotic state, paroxysmal nocturnal hemoglobinuria.
Hemoglobinuria.
Do you know any viral infection which can produce problems?
So malaria.
Parvovirus infections and some viruses can produce suppression of bone marrow. Yes. So, okay. So, as far as undergraduates are concerned, I think you have got some important causes. But suppose a patient is having cirrhosis liver and pancytopenia, what will you suspect?
Cirrhosis liver, pancytopenia. Due to some
Hypersplendism, secondary hypersplendism can produce. And pancytopenia can be cause of drugs also. When you use cytotoxic drugs can produce problems. So we have a problem of pancytopenia in this case. So when you have this type of list of cases, list of causes in your mind, what all things you want to see in general examination? You told that you have a lot of causes now. You told around 14 causes so far to me. So what all things you are going to look for in this patient to find out? Pallor is definitely there. Very good.
Then we'll check if the particular person has jaundice.
Jaundice. Why do you want to look for jaundice in this patient?
The patient might have hepatitis, acute hepatitis.
No, we have to look at this patient from the angle of pancytopenia. I agree. Sometimes hepatitis C can have pancytopenia. Yes, but why do you look for pancytopenia in this patient? Can you see some combinations where there is some pallor, some jaundice, and pancytopenia? Can you think about any aplastic crisis?
Congenital condition.
Hemolytic anemias with aplastic anemia. You can have some hemolytic anemia. In simple B12 deficiency, some amount of hemolysis is also expected. You can have
Yes, sir.
jaundice. What else you look for?
Okay. Then then we look for edema. If there is any edema,
Will you look for bone tenderness?
bone
It will
tenderness,
give a clue whether it's a myeloma or is it some myeloproliferative
joint one.
lymphoproliferative
Uh,
disease leukemias. Okay, you have to definitely look for spleen and liver. Very huge spleen, pancytopenia. Think of
mm,
myelofibrosis.
myelofibrosis. Yes, sir.
Okay, hepatosplenomegaly. Commonly, you think about hypersplenism. If there is
Yes,
stigma
sir.
of liver disease, you think about hypersplenism.
Yes.
This particular
Yes, sir.
patient has got some, what is happening, pallor is present, and then what next?
Pallor is present, and then she gives extremities are pigmented.
Pigmented. So in relation to this particular patient, what are the causes of pigmentation?
One might be vitamin B12
That's
deficiency
right,
is called
vitamin B12 deficiency is one cause.
deficiency.
That's very good. So tell me some causes where you have pigmentation in general medical wards. We may get
Then
patient general medical wards.
hyperpigmentation can be seen in Addisonian's crisis.
Not Addison's crisis, Addison's disease. Addison's
Yes,
disease. Now tell me, where do you get this pigmentation of Addison's disease? You get pigmentation in these unexposed areas. So it will be
yes,
commonly the extremities. And people who sit like me with the elbows kept here on the table or on the chair, the pressure points you
yes, sir.
get. And whichever areas are normally pigmented, like knuckles, palmar creases,
Knuckles.
areola of the nipple, your lips,
Yes, sir.
these areas get into trouble. And last is, if you are sitting back, then your interscapular area will be having the pressure points.
Yes, sir.
So Addisonian pigmentation, Addison's disease produce pigmentation in these areas. So you told so far two important causes. One is B12, relatively benign. Addison's disease very important because if you miss the emergency, the patient may die. Other causes of
So
pigmentation.
then acanthosis nigricans, which can be seen
Excellent.
in
Where do you look for acanthosis nigricans?
so neck areas, armpits.
You look
Then
for the flexors. Commonly,
yes, sir. Flexus. Yes,
as
flexus.
acanthosis nigricans can be seen. There are different types, different type. One is called acral type, where you have pigmentation in the acral areas, which can be normal in people who are having basically insulin resistance. And you can have in endocrine causes, where the insulin resistance again, you can have diabetic patients. And unknown reasons you can have acanthosis nigricans, or it may be part of what you call malignancy. You can have particularly acanthosis affecting the palms in gastrointestinal malignancies.
Yes, sir.
So you look for flexors, axilla, groin, elbows,
Groin
flexors.
region.
You can, so three causes you said. Other causes.
Other causes.
You said B12 deficiency. Now can you tell me the cause of B12 deficiency that you can look for? What is the cause of B12
Uh,
deficiency? History,
Vitamin B12 deficiency.
history,
Dietary.
dietary.
One is dietary.
So you have to take diet history.
Diet
Okay.
history.
So
Yes, sir.
diet history is important. Suppose you have a vegetarian like my friend Arjun who is not having anemia. How to explain that?
And,
But so
he might
B12
be
for him.
he might be taking vitamin
He is
B12
not taking anything
medicine. Mm,
because you have got lot of organisms in your intestine, normal
intestine. Yes, sir.
microbiome which keeps on synthesizing adequate amount of B12 unless it is
Yes,
altered
sir.
by some disease or some drugs. So they don't
Yes, sir.
commonly suffer with deficiency, right?
Yes, sir.
So
Yes, sir.
and the amount of vitamin required is very small, and the storage is for 3 to 5 years in the liver, so it will take long time. Other cause of B12 deficiency,
Then, due to any gastric pathology, might like gastrectomy done in like this
gastrectomy done.
patient.
Why gastrectomy produces problem?
So when we we do gastrectomy, in the gas there is parietal cells. So there is loss of parietal cells, which
So
leads
what?
to loss of intrinsic factor.
Intrinsic
So
factor
loss of intrinsic
deficiency.
factor deficiency. So
Any other stomach disease can produce this problem.
so then in older patients, hypochlorhydria is present.
How does hydrochloric acid is involved in B12 absorption?
So in older patients, less acid is produced. So
Okay, that's enough for you for undergraduate purpose. The acid is enough. Okay, don't worry. We don't discuss with you why acid is important here. So that's another cause. Any other cause for
so
any
then
other clue for B12 deficiency?
pernicious.
Nah. How do you recognize pernicious anemia? Your friend Arjun has come to you. What physical findings will give clue? He's having possibly having pernicious anemia.
He might be having
Vitiligo, autoimmune markers,
vitiligo.
history of other autoimmune
Vitiligo.
diseases. Alternatively,
Yes, sir.
you may have premature graying of the hair, which may give clue that he is having B12 deficiency.
B12 deficiency.
There may be stomatitis. Okay, so other things may be there. Anything else can you make out? Any other endocrine disease where you can have pigmentation? Which hormone is involved in pigmentation?
Melanin.
Melanocyte stimulating hormone. Where does it come from?
Yeah, melanocyte.
Where does it come from?
Sir,
ACTH. So any situation where you find ACTH is elevated, you get so Cushing syndrome. You can get.
Cushing syndrome.
Okay, so you very good. Cushing syndrome you can have. Sometimes you find in hyper and hypothyroidism also you may get some. Okay, name some drugs producing pigmentation. Very common in medical wards. Patients come to outpatient, say, I don't like this drug, stop this drug. What are the cause of pigmentation? Suppose you are treating a patient with rheumatoid arthritis. Patient say, I don't want this drug. Which drug is in trouble? Possibly chloroquine. And even cardiology, which drug may be the culprit? It may be amiodarone. In psychiatry, it may be phenothiazines. Suppose you are treating a patient for cancer, which are the drugs commonly given for cancers? We do come across such patients here. Yesteryears, CML used to be treated with a drug called busulfan. It is not given anymore. Nowadays, we are giving younger brother of busulfan called hydroxyurea. We give for polycythemia. You have different kind of hydroxyurea is given, and that produces pigmentation. Rarely cyclophosphamide is a culprit. The last class was on bronchogenic carcinoma, and said we use a drug for chemotherapeutic purpose called sorafenib that can also produce. And if you are in the habit of treating retrovirus infections, which antiretroviral drug can produce? Sidobidin and phenothiazine for psychiatry. So different specialists use fluconazole, ketoconazole by dermatologist. Clofamazine used for which condition? Is it given for leprosy? Yes, it's given for leprosy. And whenever you see this type of patients, always take history of other medications. Other medication other than modern medicine, which may be basically heavy metals, which can all produce
gold,
which can produce pigmentation, and it can affect bone marrow as well. Can you highlight some important points producing genetically predisposing pigmentation? It is not very important for medicine people, but it may be useful for surgeons. They can spot some pigmentation in the hands, lips, mouth, and come out with a diagnosis, which they think is important for the small intestine. And it runs in families, autosomal dominantly. Peutz-Jeghers syndrome. Peutz-Jeghers syndrome. Okay, mouth, lips, hands, and all. And a different type of pigmentation can be seen in liver diseases, hemochromatosis. So just don't ignore this pigmentation here. So pigmentation, so far we said many causes. So these causes should point to you. This is what you do in the history taken examination, drug history.
Okay, sir.
Whether he has gone to any other specialty for any other treatment which the patient ignores. They may not reveal they are having psychiatric disease, phenothiazines, antidepressants. They may not tell you. He will not tell you he is on pseudovidin for retrovirus infection. He would like to hide. He will not have. He will not say he is a leprosy. Okay, you have to probe further and further. Okay, so is it the increased ACTH producing increasing melanocyte stimulating hormone which produces the problem? So this particular patient was having this also. Coming to the other system examination, what do you find?
So all the systems were normal. CSRS, CNS were normal.
CNS, couple of points are given specifically. What are they?
So vibration sense, deep
Vibration sense is given. Yes.
deep tendon reflexes,
Yes.
and higher mental functions.
Okay. Why this B12 is given? Why this vibration, pigmentation, deep tendon jerks, and higher functions are specifically highlighted?
Just to check that if the if it is due to vitamin B12 deficiency, or is there any neurological manifestation?
Why higher functions here?
Higher functions means the patient might have dementia.
Dementia. Is it treatable or non-treatable dementia? Reversible or otherwise?
It's not treatable.
It is reversible. It is reversible. One of the common cause of reversible dementia, just like hypothyroidism, meningioma.
Yes, sir.
This is also a treatable type of dementia. Okay.
Dementia.
So why do you are looking for deep tendon jerks?
Because there might be loss of reflexes.
Loss of reflex in ankle jerk may be absent. Posterior column may be in trouble. So they may have come with the sensory ataxias.
Sensory ataxia.
So sensory ataxias. So you are talking about vitamin B12. Tell me about vitamin B12. What is it required for?
Vitamin B12 required for
What are its functions? It is required for DNA synthesis. That's why.
Yes, sir, DNA synthesis.
Right. That's why
DNA synthesis.
cell maturation is going wrong. It is going wrong not only in the RBCs but the whole body. That's why you are getting glossitis, stomatitis, and all. How is it related to this nervous system?
It is related no.
Myelin formation. That's
Myelin.
right. Myelin formation is involved in the. So it's a process of demyelination that produces the subacute command degeneration, peripheral neuropathy, and so on.
And
What are the different forms of vitamin B12? Biological forms of vitamin B12. Cyanocobalamin in the food. Hydroxycobalamin.
Hydroxy.
When you replace, you give hydroxycobalamin. What are the types of cobalamin inside the human body? Storage forms. The liver, how is it stored? These are called 4 types of vitamins. Adenosylcobalamin is stored in the liver, and methylcobalamin in different other cells it's in. So what is the requirement of B12 per day? How much you B12 you want to consume in the food, and how much is absorbed? You require 30 micrograms, and 3 micrograms will be absorbed per day, and you are storing only 3 milligram in the human body. But where is it stored? Liver. And how long it lasts? The 3 milligrams? 3 to 5 years. So deficiency will come later on. Our patient underwent gastrectomy in 2014, and she's coming now with she's coming with full-fledged deficiency. Suppose it is a folate requirement. How much require folate? Same, 30 micrograms is required per day in diet, unless there is excess requirement. So B12, what is the source of B12?
Source of B12, green leafy vegetables.
B12 is always obtained from non-vegetarian foods. That's why the vegetarians are suffering with.
Yes, so meat.
Folic acid, where do you get from?
Folic acid.
The term for folic acid came from the Latin word called folium. Folium. You will take a book. What is folium? Folium is a leaf, leaflet. So leaf, green leaf vegetables and fruits is a common source. So commonly Indians don't suffer with folic acid deficiency unless you are edentulous, you are old, you don't eat vegetables, you cannot go to market buy vegetables, you skip food because you don't want to eat, or you have some other malabsorption problems. And some countries have got this what's called fish tapeworm, which produces folic acid deficiency. Where is it fish tapeworm seen? Don't worry about that. So what are the requirements? Increased requirements for folic acid. Which are the situations where folic acid needs to be supplemented? Normally Indians don't require it. When do you want to supplement? Pregnancy, okay. Pregnancy, particularly if it is twin pregnancy, multiple pregnancy, or hyperemesis gravidae, you have to give. How does it protect pregnancy? Yes, your neural tubal defects are prevented spina bifida, so that you give. So folic acid is given. Elderly people, you have to supplement folic acid. Folic acid is required when their turnover is high. So hemolysis, basically you have to give folic acid. Malabsorption of the gut because of gut disease, celiac disease, blind loops, you have to give. Okay, different types of malignancies. Can you name few drugs which blocks the action of folic acid? Antifolate drugs used for epilepsy, phenytoin sodium. In the treatment of arthritis or malignancy, you have got what's called as methotrexate, and few types of OCPs are also said to be problems. And which contraceptive pill? Alcohol is said to be a culprit for folate. Okay, so important thing you must remember is when you check the folate levels, blood folate levels, serum folate levels may be spuriously high soon after food. That does not mean you don't have deficiency. You will have to check for RBC folate. Unlike B12 estimation, you have 2. Okay, so you have this patient under your care. So what are the investigations? So you are basically a pigmentation, history of previous history of malignancy, pigmentation, anemia, and pancytopenia. So what are the investigations you plan at this juncture?
One is complete CTC, complete blood cell.
Okay, we did one count is already done outside. That's why they say it's a pancytopenia. After coming here, we did again. It is 5 grams hemoglobin.
Then LFT.
When you have a low hemoglobin, our important thing we are suspecting is what type of RBC this patient has got. So you check for the other blood indices. What are the indices you have? What are the indices you have? Come on. Yes, you are right.
So one is erythrocyte.
MCV. Okay, what is the full form of MCV?
Mean cell volume.
Mean corpuscular volume. What is the unit of measurement of this MCV? Kilograms. What is the femtoliters? Femtoliters. So above what level you call it as macrocytic anemia? More than 100 is called macrocytic anemia. So in this patient, what do you expect?
In this patient,
you expect macrocyte if it is a B12 deficiency. If the etiology is nutritional, what type of anemia you expect? Dimorphic. That's right, dimorphic. So we have now this patient's MCV was 115 femtoliters. So this basically has got macrocytic anemia. Platelet count was 80,000 and white cell count was 3,950, something like that. Okay, so what are the causes of macrocytic anemia?
One can be this vitamin B12.
No, macrocytic anemia, you have to think it's a big chunk of condition. Out of these, three are
Folate.
three are also showing megaloblastic changes. So,
Yes, sir.
so you have to think macrocytic anemia, where you have got simple liver disease, simple alcoholism, simple hypothyroidism. Okay, some people have aplastic anemia, or if
Yes,
there
sir.
is a surge of reticulocyte, when you do the auto analyzer, MCV value may be found to be high. In these scenarios, you don't have megaloblast in the bone marrow.
Okay,
But
sir.
when you find megaloblast also, conditions are different. What are they?
Microblast, folate,
Folate,
folate
okay.
deficiency,
Folate, okay.
vitamin B12,
B12 deficiency is there. Then you have got
then leukemia, any
you
type of
have got
leukemia.
different types of drugs. Okay.
Drugs. Okay,
So
sir.
you have got MDS as a important member. Should never forget MDS. Folic acid deficiency. You have deficiency of B12, and then of course you have drugs producing the problem. So that you
Yes,
have to
sir.
be very careful. And this particular patient, when we check the peripheral smear, the report was it contains couple of dacryocytes. What are they?
Okay, sir.
What is dacryocyte? Dacryocytes are also called as teardrop cells.
Okay, sir.
So we just name few conditions where teardrop cells are seen. Name one condition.
Hemolysis,
One common condition we always think about.
iron deficiency anemia.
One common condition we look for is myelofibrosis.
Okay, sir.
Okay, so we find that plenty of dacryocytes. Incidentally, this patient's LDH was found to be 4000. What is LDH?
Lactate dehydrogenase.
Lactate dehydrogenase. How many isoenzymes are there? What's the importance of estimation of LDH in these patients? LDH is present in almost all cells.
Yes,
So when LDH is increased, you think about some cell destruction is going on. It can be a marker of internal neoplasia, lymphoma,
vitamin B12
hemolysis,
deficiency.
megaloblastic anemia. So
Yes, sir.
lactate dehydrogenase has got very non-specific but important clue to give that something is going on somewhere. That's all. It may not be
Yes,
specifically
sir.
diagnosing any condition. Now, what is the role of
Yes, sir.
LDH? What does LDH do?
Mm,
LDH
Sorry,
convert
don't.
lactate into pyruvate and vice versa.
Yes, sir. Lactate into pyruvate. Yes, sir.
Okay, and NAD is converted into NADH, and that is the sole purpose of this. So this patient has got
Okay, sir.
patient has got also got some teardrop cells in the
Teardrop
blood.
cells.
Okay,
Great.
and this patient's B12 was estimated it was 30. It's very low,
Okay, sir.
very low.
Yes, sir.
So what do you suspect now?
So vitamin B12
Vitamin B12
deficiency. B12
deficiency.
deficiency.
So what's the reason for that? She is a non-vegetarian.
This might be due to gastrectomy, which was done 6 years before.
Okay, this may be because of gastrectomy which was done few years back. Because there is a history of malignancy, it is important that we also check for the bone marrow of this patient to rule out rare possibility of a metastasis also.
Yes,
Okay,
sir. Okay,
and
sir.
how are you going to replace it?
So we can give vitamin B12. Can be treated with hydroxycobalamin.
How much you give?
So 1000 micrograms
1000 micrograms given,
intramuscular.
intramuscular given,
Six to
or given, yes.
2 days apart.
Then
2 to 3 days apart.
then what you do?
Can give. Then we should give maintenance therapy.
You have to give
1000
maintenance therapy. Yes.
1000 micrograms in every 3 months.
Every 3 months has to be given. Suppose the patient is not willing to take intramuscular injection, what will you do? Patient say, I am not agreeable to take injection, what will you do? Hmm? So there is option. So when you look at the absorption of B12, it goes with the help of intrinsic factor, and if you give large doses, it's another independent mechanism of diffusion. So if a patient is not willing to take injection, you can always give 1000 micrograms orally, and it will very much be absorbed if stomach is intact, ileum is intact, and everything is perfect. So every day you have to give 1000 micrograms. Suppose you don't have stomach, suppose you don't have ileum, okay, so sites of absorption or intrinsic factor is absent, even then you can give 2000 to 3000 microgram orally. By a process of passive diffusion, B12 will go into the body. And how long will continue?
So this may be lifelong.
This may be lifelong. This may be lifelong. That is true. Provided
Provided the patient does not
it is a pernicious anemia.
any neurological.
Provided it's a pernicious anemia. Suppose it is only temporary thing, patient is prepared to change the food habits, may not require it. So all depends upon the scenario through which you are passing. Okay,
Okay, sir.
that's right. So another option you said in this patient, macrocytosis, was MDS. That's a dangerous thing. What is how do you define MDS?
So it is defined as bone marrow failure due to which can be due to anemia and recurrent infections and bleeding.
Okay, you are somewhere there. It's a group. It's a group. It's not one condition. There are different members of this group. So it's a group. Is it a congenital or acquired condition?
It's acquired. No.
Acquired. It's acquired.
Acquired.
Yes, yes.
Acquired.
Where is the problem? It's a clonal disorder affecting the hematopoietic stem cell.
Yes, yes,
Okay.
cytopenias.
And characterized by. So fifth step is characterized by cytopenias belonging to any lineage.
Cytopenias.
But there is one clue that the bone marrow must be normal and hypercellular. You cannot have hypercellular marrow like aplastic anemia and such is MDS. It has to be hypercellular marrow, and blood must show morphological changes in the RBC or WBC or platelets. Okay, so you may find macrocytes, you find
Red cells.
hypogranulation, hypergranulation, hyperlobulation. Okay, so different types of abnormalities can be seen, dysmorphic changes in the cell lineage can be seen. That's called as a MDS. The previous term for MDS was leukemic leukemia, pre-leukemia. Those terms are all taken off, and there are now 8 types of different types of MDS. Okay, for 8 different types of MDS are there as per classification. And when you go to the further workup of these cases, you require the genetic studies. Okay, you have to look at karyotyping, is it, chromosomes has to be looked at, where is a deletion, where is a addition. Okay, so that based upon that you tell the prognosis, based upon that you decide the treatment, and that's how it goes. That's right. So what are the cause of MDS, by the way? What are the cause of MDS?
Causes can be infections. Then
Causes can be family history, maybe tobacco, maybe ethanol, maybe the heavy metals you are consuming. And in our country, plenty of insecticides and pesticides going around. it can create problems. Maybe some irradiation, radioactive iodine, okay, infection, you rightly said, okay. So chromosomal abnormalities may be a problem, JAK2 related problems may be there, BCR-ABL may be the culprit, okay. and and some people even say it can be hepatitis B, hepatitis C, parvovirus infection, all can predispose for MDS, but the exact etiology still remains unknown. Okay, so today's case is telling you the importance of clinical examination. This patient came with the history of CA, so there's obviously a possibility of a metastasis, but the clinical examination showed very good pigmentation, and the picture was given to Arjun for circulation. I'm sure all of you have seen the pigmented hands compared with, okay. And this patient also had abdominal examination. What was happening?
So he has 1 centimeter hepatic enlargement, tendonless with firm consistency.
Okay, so this patient underwent a liver function test that is found to be normal. So further investigations of these patients is one is bone marrow, which is pending, but so far we have found that this patient has got low B12 with the pigmentation. We are replacing the B12 and waiting for
B12.
the response. Once you give B12, when do you will get the response? And how will you see the response?
You check the levels of cobalamin in the body.
You check the levels of, no, you want to see whether
No.
body is responding. That's what the question. You are given the cobalamin is in the blood. Yes. How will you know the patient is responding or not? So you have to go for reticulocyte count. After how many days you will see the response?
So 5 days.
5 to 7 days. Okay. So what is the basic difference between reticulocyte and an RBC?
Reticulocyte is the precursor.
Which is larger?
Reticulocyte is larger.
Yes. Has it got a nucleus?
No, yes, sir, it has a nucleus.
It has no nucleus, only RNA remnants.
No.
Okay. How do you differentiate a reticulocyte count from RBC? How do you demonstrate it?
RBC is biconcave.
So you have seen RBC, biconcave RBCs in the
Stain.
peripheral smear. What stain you use? So they are called supravital stains, like
Okay, sir.
brilliant, crescile, blue. And how do they look like?
Okay, sir.
They will look like a large cell with this. You can, in that position you can see this reticulin network can be seen like dots in a straight linear line. Okay. And in the peripheral blood, how does this reticulocyte look like? What's the term commonly used?
I don't know.
Okay, so peripheral smear is commonly described as polychromasia. It will have a bluish tinge and will be larger in size.
Okay.
So that's how they look like. So B12 deficiency can be suspected clinically provided you make a proper evaluation by examining the patient and take proper history. Okay, this is a classical example of a patient with B12 deficiency. They can have splenomegaly also. If the splenomegaly is present, obviously you have to look for any hematological problem producing these entities. Okay. Yeah, now it's time for questions by undergraduate students. If you got any questions, you can ask. If there are any questions coming up, nobody is writing anything. In which case, the undergraduate students can leave, and you will continue with the postgraduates.
Thank you, sir.
Okay, thank you. So, postgraduate students, the questions come to you. you have to tell basically how is this B12 absorbed. Dilruba will start the ball rolling. How is the B12 absorbed? They specifically said about hydrochloric acid. How does hydrochloric acid come to the picture?
Vitamin B12 combines with the R binder in the saliva in the body, and it combines with the intrinsic factor in the stomach, and it gets released from the parietal cells of the stomach. That is, the intrinsic factor remains in the lumen, and vitamin B12 enters into the cells of the parietal cells, and uh, and it is absorbed in the ileum.
What does hydrochloric acid do? What does hydrochloric acid do?
Hydrochloric acid.
What does hydrochloric acid do?
Intrinsic factor binds
The intrinsic factor binds and it
with the
takes up to the ileum where it is removed. In between, you have got what is the role of pancreas? What does pancreas do? Are the pancreatic enzymes required for the proper absorption?
yes, yes, sir.
Yeah, how?
Trypsin and
Acid frees the protein bound B12 in the stomach. Okay, that's its role. So, what's the clinical application of this step? If you give H2 blockers, if you give PPI for a long time for a patient and suppress hydrochloric acid, theoretically you can have vitamin B12
vitamin B12
deficiency. So we have hydrochloric acid, we have got the enzymes from the pancreas and intrinsic factor which are helpful for the procedure. Okay. Now coming to the pigmentation, we didn't discuss much about rare things. What is Nelson syndrome?
Nelson syndrome is usually seen is a condition with bilateral adrenalectomy. That is, patient presents with hyperpigmentation.
No, when you
Usually
do bilateral adrenalectomy, what are the indications?
characterized by
When do you do bilateral adrenalectomy?
usually for Cushing's
Bilateral disease. Bilateral.
bilateral disease.
What? Bilateral what? Adrenal hyperplasia. So what will happen? The feedback is taken off.
Yes.
So what will happen? ACTH comes in excess. So that will be converted into melanocyte
MSH,
stimulating
melanocyte stimulating hormone,
hormone.
producing hyperpigmentation.
Okay. Now coming back to the MDS, what are the morphological abnormalities you are looking for?
Morphological abnormalities you have to look for is anemia, reticulocytopenia, anisocytosis, folliculocytosis, macrocytosis, basophilic stippling in the peripheral blood.
So what do you
We
look for in the WBCs?
In the WBCs, usually
What happens to the granules? Hypergranular, hypogranular.
hypergranular,
What happens to the nucleus?
hyperlobularity will be there.
Hyperlobularity will be there. Yes,
Yes.
yes. Any other name for that?
Um,
Okay, what happened to platelets? What all things
platelets,
can
there can be thrombocytosis or thrombocytopenia.
What is size of the
With
platelets?
megakaryocytosis, it will be increased.
Giant.
Large
Okay,
platelets, giant platelets.
that's right. And how are you? What are the different types of this MDS?
MDS, according to the FAB classification, it can be of refractory anemia with ring sideroblast.
No.
Refractory
The
anemia.
current classification is not based upon ring discoblast. It's all gone now. No, 2018 classification. What
It's
is it?
based on
Ah,
uh,
Genetic studies.
Malnutrition.
Genetic studies.
Okay, sir.
Ah,
Based on the
single
cytogenetic
single
abnormality.
lineage. Then next is ring cerebroblast. Third one is multiple lineage. Then their fourth one is multiple MDS with excess blast, EB1, EB2. Then we have got isolated deletion of 5q. Then you have unclassified. Okay. Then you have got separate entity for children. So these are 8 different types of MDS. Okay. Coming to back to this patient, can this be hemophagocytic lymphohistiocytosis? What is it and
Uh,
what happens?
Hemophagocytic, it's a fatal disease with
What is the
ablation
what is the
symptoms.
culprit? What's the culprit? Who is the culprit?
Usually it is a macrophage activation.
So it is a marked T cell
Macrophage
activity,
cell
increased T cell activity, showing what? Hemophagocytosis.
hemophagocytic.
So T cell activated macrophages do what?
It will engulf all the
RBCs,
immune like
WBCs
T
and
cells, WBCs,
platelets, and their progenitor cells
blood
are
cells.
also. So what are the symptoms and signs which they come?
Patient will present with anemia, pancytopenia usually,
What is the
with
symptom?
hepatitis A.
What symptom?
Symptoms usually infections, persistent fevers,
Fever.
uh,
Fever, splenomegaly,
then yes,
and
rash,
then you can have hemophagocytosis.
hepatitis